And then we come to protease release. We don't want to encourage the development of too much collagen because too much collagen is fibrinous. Fibrinous is deleterious to wound resolution. So we have a balance. Do you agree with me that the fibroblast is such a cool cell? And it's so influential? Yes, very influential. This is a great slide. Great slide. Okay, so let's talk about, focus on diabetic neuropathic wounds. Remember we talked about type 1 and type 2, particularly type 2, which is adult onset. That's the highest prevalence of diabetes. I mentioned that is because of its an insulin resistor to the receptor. Here's what happens. Let me give you the pathology, the pathophysiology of a diabetic wound. When glucose is hanging outside the cell and cannot get in, it goes into the nerve. The nerve swells. Over time, the nerve shrinks. When the nerve shrinks, it forms scarring. And a scarred nerve cannot efficiently transmit an electrical signal. So what happens? The patient has pain, tingling, numbness, and paresthesia. So if you have 1 grain of sand in your shoe, and you have peripheral neuropathy secondary to diabetes, or even peripheral neuropathy that's idiopathic, you're not going to feel that grain of sand. So what's going to happen? You're going to initiate a break in the skin, and you'll develop a crater like this with a halo. You see the halo here, a calloused halo? This is a chronic wound. Here's the important take home again, is that collagen will heal these wounds. Even though the patient has a wound for 15, 20 years, I would like to submit to you the awareness to create your awareness about collagen. Consider collagen. And I know there's so many wound products out there, but I'm a big proponent of collagen. I've been in wound care for years. And I've gotten to see a lot of wound care products out there. And you know what? It always comes back to the simplicity of it all. Keep it simple. Use collagen. Heal the wound. And not only in diabetic wounds, but collagen for vascular, venous stasis, arterial insufficiency, decubitus, bed sores, acute trauma, traumatic wounds, surgical, every type of wound, skin tears, partial thickness, full thickness, even first and second degree burns. One solution for many problems. Okay, so diabetic neuropathy. All right, here's a great slide. Another good slide. We see an acute wound. Let me give you a definition between acute and chronic. If an acute wound does not heal within about 6 weeks, it's diagnosed as a chronic wound. So 6 weeks is your time, around your time frame. And we see in a wound that becomes chronic, what happens? We have those MMPs, matrix metalloproteinases. We have bacterial bioburden colonization in the wound. We have a proliferation of exudation, and we know exudation carries the bioburden, carries the bacteria. And the bacteria inhibits the growth of fibroblasts. When you put collagen in a wound, you reduce the MMP. You initiate fibroblastic proliferation secondary to growth factor release, also utilizing your cellular mediators. And the big cellular mediators you're going to induce are called cytokines, lymphokines, interleukins, IL-6, IL-8, and IL-10. I'm getting to another level of technicality, but I can tell you one thing. When you get to this level of wounds, there's a lot of stuff going on there. It's a very dynamic process. So the take home here is an acute wound becomes a chronic if you don't heal the acute wound in what, how many weeks?
6 weeks.
Thank you, 6 weeks, wonderful, okay. So what is the benefits of collagen? There are many. Induces fibroblastic proliferation, is chemotactic, we know that because as we saw on that slide, it's chemotactic for macrophages, it's chemotactic for a lot of other cellular elements. It's autolytic. Autolytic is a great word for cleaning itself. That's a good property of a product, okay, molecule. Angiogenic, initiates new blood supply. Hemostatic, preserves the blood supply, we don't bleed out here. Is biodegradable, which means the body metabolizes 100%, it never has to be removed from the wound bed. Minimizes the potential for scarring and reduces wound pain. Let me talk about these two things very quickly. Anyone in dermatology? Okay, wonderful. You're going to like this. If you have a patient who has a after a status post-dermatologic procedure, like a microdermabrasion procedure, they're painful. A microdermabrasion procedure induces a first-degree burn, or even the patient has a fractional laser procedure, correct? If you use collagen on that patient, you reduce wound pain. You reduce wound pain because you form an occlusive dressing property. Moreover, you minimize the potential for scarring. What a great aesthetic benefit for your patient. So you're doing three things. You're growing new tissue via fibroblast proliferation, you're reducing wound pain, and number three, no scar. Not bad. Where can you go use one thing and have three great benefits? Collagen can do that for you. And remember, in the chronic wound, we have a lot of MMPs. Those are stalled wounds. They're also called recalcitrant wounds. You want to turn a stalled wound to a healing wound, you use collagen. Collagen is your best source to go to heal the wound. We can also use collagen for wound complications. I have seen many times in managing a wound, there's a lot of undermining there. If you put the collagen in there, it seals the undermining. If you put it into the tunnel, it seals the tunnel. If you have a fistula, and you blind pouch the end of the fistula, you put collagen in there, it seals it up. So you have a wonderful application. You can use collagen mixed with any topical antimicrobial, whether it's an aminoglycoside, vancomycin, doxycycline, tobramycin, gentamicin, whatever you'd like, whatever you clinically determine, put it in the wound bed. Not only are you managing the bioburden, but you're also starting to granulate. So collagen can be used in any clinical setting. Also good for skin tears and flaps, burns. Collagen is approved for first and second degree burn management. Biodegradability I mentioned. And what about biocompatibility? What does that mean? Well, you can use it. How many use negative pressure wound therapy? Negative pressure wound therapy. If you put collagen in the wound bed and apply a negative pressure system, you'll grow tissue fast. Here's why. Because the collagen is going to induce the fibroblasts to produce granulation tissue, and what happens is the negative pressure therapy system pulls all the exudation off. If you remove the exudation, you don't have bacterial growth. You don't have those MMPs develop. You're letting the wound do what it needs to do with the use of the collagen. Very efficiently and very effectively. So negative pressure. This is biocompatibility. Also, you can use collagen with hyperbaric oxygen therapy, HBOT. Those chambers where the patients are inserted because they may have chronic wounds like pyoderma gangrenosum, which is a very stringent cutaneous manifestation secondary to immunologic deficiency. I've seen patients in Florida where they've had pyoderma gangrenosum, they can't heal. We put collagen in the wound, put them in the chamber, in 3 chamber visits, those wounds are healed. That's pretty impressive for medicine. We're able to restore the patient's quality of life by healing the wound. Very, very important. Okay, and this is what we want to end up with. Granulation tissue, beautiful red, vibrant tissue, vital tissue. This is your reward, and your patients will thank you. Indicates healing. Okay, so, another good slide. Here's an equation I put together. The common denominator is collagen. But however, there are other factors we have to consider, obviously. If a patient has a trochanteric wound or a coccygeal wound, we have to also